I'm Dr. Satya Yadav, and it's a pleasure to, you know, to invite you to this inaugural meeting of Society of Pediatrics Cell Therapy and Transplant SPECT, and I welcome you all to this meeting. The this society was established almost a year back, and finally, it's good to see that the academic programs have started now. This is the first academic program, and we intend to have every month some topic related to bone marrow transplant and cell therapy to be discussed with focusing on young trainees in this field and faculty who are younger or who have just entered the field of bone marrow transplant. And we tend to we'll be focusing more on the practice or India centric approach to managing things. That would be the focus of this group. And the first webinar is going to be held today. And I'll ask Sunil to tell us a bit more and then to start today's proceedings with the chairperson for the first session. Over to Sunil. Thank you.
Thank you very much, sir. So good evening, everyone, and welcome to this inaugural meeting. And as Dr. Yadav just mentioned, it's been few months that we have been working the back end to have the society up and running. Thank you very much for overwhelming responses for the membership drive which we had, and within a couple of days we had more than 115 members, and those who are not been the member yet, so we can request them to write to us and join as the member as well. The objective is to have academics as well as collaborative work from India. Academics, this is the initiative which we have taken today, and this will be a monthly event. And we are working on some additional academic, programs as well, which eventually I think will unfold as the things get more and more materialized. Collaborative work is already kind of started, so we would kind of reach out to each one of you, and any one of you wanting to do that under this umbrella are more than welcome to submit your ideas, projects, so that we can collectively make some difference and add to the literature from India especially. So it gives me immense pleasure that we have the stalwarts in the field in this inaugural meeting, and that was the intention to start with the blessings of the most senior people in the field. It's indeed a pleasure for me as well to introduce the chairperson for this session. Dr. Mamta Mangalani ma'am does not need any introduction to whosoever is listening to us. Illustrious career spreading over decades, immense experience in the field, especially in the field of hematology, with focus on hemolympathies and related disorders. And I think we all know the contribution ma'am has made in the field of stem cell transplant as well. I'm proud to say that's probably one of the most successful bone marrow transplant units in the country in the public field, and that too established in a very, very short span of time. And I think the credit goes to ma'am to make that happen. I had a pleasure of working with ma'am as well, in the capacity of the secretary of the PHO chapter when she was the chairperson of the chapter. And, I had great mentorship during that period as well, with ma'am being at the helm of affairs. So it's our honor, ma'am, to and thank you very much for accepting this invitation. And we couldn't have a better team to inaugurate this inaugural session of our academic webinars, which are going to be a monthly affair, as I said. So thank you very much for accepting our invitation, and over to you, ma'am, to have this session on history of stem cell transplant. Thank you very much.
Thank you, Sunil and Satya. And I wish to congratulate all of you young people who are now the stalwarts in transplant and cellular therapy, including Gaurav, Satyendra, for putting this society up for pediatric cellular therapy and transplant and making it as vibrant as it can be, because I'm seeing so many people already have become members. So with these few words, I would start the introduction of the first speaker, who better than Lieutenant General Dr. Velu Nair, whom I know personally too, through our interactions in conferences as well as examiner, co-examiner. When he used to come to Mumbai as examiner, I've had the opportunity to know him. A great personality, a vibrant person, as you can see, young as he seems. And also, you must know the credentials that he holds are so many that if I were to read everything, then I think we'll not have the talk on history of stem cell therapy today. So I will be brief. So I'll not be actually reading out everything, but I'll highlight whatever is something which we all need to know about Dr. Velu Nair, Lieutenant General Dr. Velu Nair. Pardon me if I miss out on your title sometime. Presently, Lieutenant General Dr. Velu Nair is the Head and Chief Consultant Hemato-Oncology and BMT at Apollo Cancer Center, Ahmedabad. He's a gold medalist in MBBS. He did his MD Medicine in 1987 from Armed Forces Medical College, which you know is a prestigious college. He did his postdoctoral fellowship in hematology and BMT again at a very prestigious institute, Christian Medical College and Hospital, Vellore. He has also had the fellowship at King's College and Hospital, London, Stanford Medical Center, and Stanford University, USA. I think this speaks for what he has achieved through his career. He has been formerly the Director General of Medical Services, Army, Residence Honorary Surgeon, Dean at AFMC Pune and Army College of Medical Sciences, New Delhi. He's been the President of National Society of Hematology and Transfusion Medicine and Delhi Society of Hematology, Chairman of Accreditation Committee. Presently, he is President-elect of NAMS, New Delhi, founder member of Indian Myeloma Academic Group, elected council member of National Academy of Medical Sciences, and many other laurels to his credit. He has developed hematology and BMT services. He's been awarded for developing hematology and BMT services. He is Scroll for Excellence in Medical Education by NBE. He has established in the Armed Forces Hematology and BMT centers, been a teacher and examiner for MD, DNB Medicine, DM and BRMB Hematology, as well as PhD. Of course, you can imagine he has so many publications, being an avid researcher, 300 in various international national journals. I think that's amazing. I need to reach there still. He has published guidelines. He's been the chairman of the drafting committee for various guidelines and task forces, and has had the prestigious Presidential Award for Distinguished Services in the Armed Forces, Param Visishta Seva Mandal, Ati Vishishta Seva Mandal twice, and Chief of Army Staff Commendation Card 4 times. I think absolute illustrious CV. Recipient of 20 prestigious civil awards from various national societies. I think I will not go through many orations, all including Manorama Sapre and J.B. Chatterjee Oration Award. Over to you, Lieutenant General Dr. Velu Nair. Pleasure to hear you on history of stem cell therapy.
Thank you, ma'am. Thank you for those kind words. And I must firstly say that we are lucky to have Dr. Mamta chairing this session. I personally feel privileged. She's one of the most energetic academicians I've been involved with over the last few decades. And I know how difficult it is to set up this center, which she done in Bombay so beautifully in the public domain. I am from the army, and I know how difficult it is to get anything sanctioned because it's multi-tiered. In a corporate, if the boss wants a transplant program, you get it. While if you go to any system, state or central, it's multiple tiered, which you have to actually percolate through before you get an equipment and before you get an infrastructure. So I think she done great work. That's one. And this can't be without exemplary leadership, ma'am. And we salute you for that. I think the future of any country, forget about any subject or domain, depends on the next gen. And here is the next gen sitting in front of you. And I've been so proud that I've been involved with them in the last maybe, 10, 12 years. And it's been, a pleasure because they're all proactive academicians with boundless energy. And I bless them that they should carry on having this. That's the first thing. And they must always learn how to be inclusive and not exclusive. that was one of the beginnings of this society itself. So I must say that, history in the military, we say, is the biggest teacher. Without history, there is no futuristic battles or wars. And battles of war doesn't have to be by, in the realistic term of the military war, it can be against diseases. And that's what we guys are doing. So I think history in perspective teaches you the past mistakes, successes, and the, boundless energy and, lifetime spent by doyens in this field in the past. And I think I would have found it much easier to give a talk on MRD, on AML, ALL, projects, no problem, clinical trials. But to talk on history and then to make it contemporary is, I think, very challenging. And it's historical that I'm talking about history in the first meeting of SPECT. So I think both ways, it's a great thing. So can we share the slides, please? And I must congratulate the 4 pillars in this whole setting up here, whom I've been involved with constantly, I would say. Dr. Gaurav, Dr. Satya, Dr. Sunil, and Dr. Satyendra Kateba, they have been backstage quietly working their way through and have managed to put this together. And I know in my lifetime, I put together many organizations and have headed many. But I know how difficult it is to start de novo. When you get a paper to correct, it's very easy. To write the first draft is the most difficult thing. Everybody knows. When you get a draft, third draft, fourth draft, I can give you my expert comments. But I know how difficult it is to make the first draft. And this, from the first draft to the final draft, and I would say on the academic front, it's been born a year ago, but here we launch it officially. And I want to congratulate this whole group. And I wish them all the very best in the coming years. And I'm sure they're going to flourish. And you're talking of 115 members. Very soon you will see this, hitting the bull market. It is going to have a bull run very soon. And I wish you all the very best. With that, I come to the business end of my talk today, which is history of BMT. The slide is not moving. Hello. Yes, okay, next. Okay, this is the overview of my talk. Every new birth of a subject has a need. And what was the need for BMT? Partly it was this, what you're seeing. This is a picture which has been flashed for many decades. The bomb dropped on Hiroshima and Nagasaki. Saw the atomic radiation could not only wipe out the marrow, could kill and also leave you as a survivor to get secondary malignancies. So necessity is the mother of invention. And here was one such disastrous killer bomb which led to the thought of regenerative medicine and transplantation. Man-made disasters, iatrogenic disasters, Chernobyl in Ukraine is one such example, killed a lot of people. And as a matter of fact, these are some of the victims. I've been a member of the Asia Pacific BMT for some years now. And since I dealt with the Mayapur victims when a reactor from the physics lab and physics chemistry lab at Delhi University was sold in the scrap market, and they found that those sticks sold were radioactive and they thought it was platinum. They were all sold for $1,00,000+ to various people. Some people kept it in their cupboards, some carried it in their pockets, but they all got burnt and many died. So the few survivors after that were sent to Army Hospital by the Army Chief on the request of the Chief Minister, Dr. Mrs. Sheila Dikshit. And they luckily survived. They had matched donors. And this led to my interest in nuclear medicine. And we worked in this field. And at the end of it, we made the guidelines for medical management for nuclear radiation emergencies, which was sent to 23 countries and has been accepted. And it's a free download in the APBMT website. And my co-chair for this drafting committee was from South Korea, Dr. Lee. And this is covering these chapters. And this is a reality. Tomorrow it can be an accident or intentional. But the way the world is today, I think the medical fraternity needs to understand this. Our government is aware, but the private sector is not. The private sector has to know that this is there and it is real. So we better know some things in Korea, Japan. They have regular workshops, regular seminars, regular drills to address this. So we've had our sessions in the Nuclear Accident Management Committee of APBMT, and I'm sure this will only grow from strength to strength. The other thing is diseases for which you have no treatment. You know, one of the reasons I took hematology was when I did my MD, I found the patients who maximally died and hardly anybody survived was hematology. So I told my wife, I think there's a lot of scope for research here. So I think I may want to do hematology, not knowing anything about hematology, because it was never taught in MD except iron deficiency and megaloblastic anemia. So if you see here, this is the 10-year survival curve of AML by age groups in 2 time periods. If you see, that is in 1990, 80 to 84, and then 20 to 24, nearly 2 decades apart. What do we see here? Let me just take the laser pointer. Yeah. So here you see 15 to 34 age group and 65 plus. And you see the dotted line is the 2000 to 2004, and the solid line is 80 to 84. In the youngest age group, you see the difference between the 2 lines. It is nearly, this is nearly 50%, and this is, 15%. So how come this line is so separated? These lines, graphs are separated. Refinement in treatment, chemoradiotherapy, supportive care, and bone marrow transplantation. But the older age group, dismal, less than 10% at the end of 10 years. Why has there been no improvement here? The reason is they were not included in most of the trials like transplant and refinement in higher doses in chemoradiotherapy. They were excluded by and large. So they never got the benefit. But today this is an area of research, and today we are transplanting people who are in a good shape in older age groups. So this was another necessity, said we must get going with BMT. So the history of early concepts of global context, it may sound boring to the youngsters, but I'll tell you, as you grow older, you realize the importance of 2 things. COVID taught us, those who don't know public health will suffer. So everybody learned public health by default. And other thing is history. You must know history. What happened before, what were the mistakes made, and that will let you know and plan for the future. And in the army, nothing is planned without the history. So history is taught and retaught. So here also, if you see, the first, this may, again, I told you not sound so attractive, but the first syngenic, 1960, the first matched sibling donor, 68, unrelated, 73, haplo in the 80s. And this went on. And this improved because in the later part in UK, the first registry for donor registries came out, the Anthony Nolan in London. I went to the registry when I was doing a fellowship in King's Hospital, and it was amazing how it was set up from the family of a patient, how it started. And same thing in the US. It was started by the Navy. An admiral had his actually granddaughter got, I think leukemia, and started from there, went on to become the NMDP, and Be the Match is the slogan. And these 2 showed that most patients will end up with a matched donor if you have enough on the website as voluntary donors. So in the timelines, the red ones have been sort of revolutionary and defining to take us to the next level. So one is, we thought bone marrow transplant is like solid organ transplant. Have the same group and you can transplant. No, sir, I'm sorry, you can't. That's when they learned HLA is important, class 1 and class 2. And from serology and cellular typing, we went on to the DNA-based typing. It made all the difference in our outcomes. Though across the blood groups, we definitely can transplant. Then came the challenges of active, various infections. And among them, the viruses were the most challenging because we didn't have enough virology departments and virology tests, and they were not validated. So we struggled. And the therapy for them was very less in the armamentarium. So it started with the CMV monitoring assays, which has come a long way. and it's been standardized and validated. Then came, okay, we're not having enough donors. And, the Baltimore, the great PTCY came into being, and you hardly were in a situation where you didn't have a donor. So the improved outcomes of haploidentical, transplants after PTCY, and those who have done it before PTCY, I belong to that group. I know how difficult it was, how much we feared doing it, and how bad the outcomes were. And it's not only about us, it was global. But how it changed the whole landscape is for all of you to see, and I'll show you the graphs. Then we came to know we should do mostly bone marrow. That PBSC is not so bad. You can have a lot of advantages. Okay, there was more chronic GVHD, but there are ways how we are addressing this, and that's one of the fields of active research. But you know that the outcomes are comparable today. And then, of course, we've gone on to various other things, how to manage the complications, and that we will talk a little bit in detail. But then the cellular therapy is also born. We only were doing DLI, but today we know CAR T cells is a reality, and the world over it's being practiced, including our own country. So this is just a very good graph. The green shows what's been achieved. The blue shows what is to be done. And what is to be done is the areas for research for all of us. And for all of us, you can see the first A is transplant preparation, that is conditioning, infusion, and tissue repair. Obviously, we know we have problems in mobilization, especially in autologous, heavily pretreated people. And, what are the non-genotoxic based conditioning, which is where we are going? Can it be antibody based? How free can we get of chemotherapy? Okay. And likewise, when you come to immune homeostasis, we are moving towards getting immune tolerance. And towards that extent, we are handling and seeing, can we tease the difference between GVHD and GVL? And that's a very exciting form of T-cell research, which is what we are actually into now. What I have said in the last 5-6 slides is summarized here. 50 is the first human transplants. 58, Dorset got the HLA, and cracked the problem of HLA. 59, Mate did the first BMT for a radiation accident. And 63, he did the first successful complete engraftment with engraftment and survival for 1 year. And he went on to describe the acute and chronic GVHD in humans. And guess what? And on the same time, Dr. Donald Thomas was working on conditioning and TBI, and that I'll just show you. In 70, there was an explosion. Clinical BMT takes off. India doesn't want to be left behind. First one done in 1983. The Nobel laureates, very few subjects can boast of so many Nobel laureates in a few decades. Let me start with Jean Dorset from France and George Snell from the US for elaborating the HLA, which we know how important it is. Then the father of modern transplant, Dr. E. Donald Thomas, gets it in 1990. I had the privilege to meet this doyen in 2008 in Ash in San Francisco, and what a humble person he is. And then in 2012, Yamanaka and John Gurdon got it for actually telling us what induced pluripotent stem cells are. And if we want to capture global and India, I would want to put 3 people. E. Donald Thomas, global. Dr. Suresh Advani from TMH, one of the first to go to the Fred Hutch, followed by Dr. Marman, who went to Westmead in Australia. And they did their transplants first in 1983 and 86. And they were honored with the Padma Bhushan by the president in 2011 and Maman Chandy by the Padma Shri in 2019. So we are a proud lot, a happening lot, and a look up to lot. To capture the Indian milestones, 83, first allogenic Mumbai, 86, first thalassemic CMC Vellore, first autologous 93, cord 96. We did our first in the army, cord in 97. And 2003, the first haplo. And we did our first autologous also in 1997 in the armed forces. And this lady is honored to be the first AML allogenic successfully transplanted in TMH, lived for 22 years. And after that, succumbed due to diabetes uncontrolled with tuberculosis. On the right is the first autologous for myeloma. And this is the first haplo child, who engrafted, and you can see happy child. So BMT in India has come a long way and undergone rapid expansion, and now has boasts, as of 22, 114 transplant centers, and we are still counting. And we have crossed 27,000 transplant as of 22. And we also have got a guideline, which in ICMR we brought out in 21, just post-COVID. Some of you have a part of it from this group, and I had the honor to be the chairman here, and that is a comprehensive document in circulation. Work in progress, we are working towards also how should we accredited BMT units. This is the first guideline, and these were the members, and we took nearly 1.5 years. It was not easy to make. Like I told you, the first draft, we went here to 21 drafts, and it was published in 21 and released by the ministry. And this is a worthwhile effort. Then we have now centers in the private, public, and trustee autonomous centers. And in the 1980s, the leaders were TMH, CMC, and AIMS, followed by ours in the Army, Hospital Delhi, Sehadri Pune, other private corporate hospital in 2000s. Shri Gangaram started, and Dr. Anupam Sachdeva, Dr. S.P. Yadav is very much here. They were the ones who started this program, and they were the first pediatric program, started a fellowship program. So heartiest congratulations, kudos for being the first to start this. But this is not without challenges, ladies and gentlemen. And we never had, when I went to Vellore, there was hardly any pediatric unit. So when I finished, I was told in the Army, you have to set it up. And 30% of my patients were peds. So what did I do? I sacrificed going abroad. And I spent 1 year in the Institute of Child Health, Egmore, with Dr. Pushpa, and did pediatric hematology and a fellowship for 1 year. And I mean, it was very exciting to work with her because we had an OPD 6 days a week. Each one of us saw 20 odd patients, did their bone marrows, did their LPs, saw the slides, started the treatment, and then went home. So that's when I thought I really became a hematologist. The PHO IAP chapter was started, and that was a very important turning event, and I took membership immediately. People like Bharat Agarwal and others, Dr. Mamta, Dr. Lokeshwar. We had many prominent people who led the way. And now we have the young next gen, which we are so proud of, putting SPEC together. And here we are talking about it in the first historical meeting. We need to not forget, to sustain this, we must not forget training. And we must have dedicated courses. I think there's an insufficiency, dearth of this. And I would certainly say we must put together courses in the months and years to come. I have done lots of this. I will be very happy to guide you guys for BMT physicians and nurses. And at the same time, keep growing capacity building, growth and expansion with technology and recent advances. We cannot leave the lab behind. I remember when I started, I was doing HLA by serology. To get the molecular platform, I had to select 3-4 people and send them to AIMS, send them abroad, and then to get them back within a year or two, set up a first molecular lab in 2001-2. So, it is not easy. You must carry the team with you as leadership, like people like Dr. Mamta, Dr. Yadav, and even, I would say Satyendra, Sunil, and Gaurav have done a great job at their own ends. The other challenge is we need more governmental involvement, especially at the level of research, collaborative research, and infrastructure building. ISBMT is there, very good. But we need obviously to build up our matching donor registry. And donor registry, we will talk about it. We need governmental involvement. Okay. We need to make disease management groups now, and I can see that this group has also published data, whether it's AML, ALL, and I see the pediatric group taking the lead there. Whether it's ICICL, whether it's others, collaborative research, wonderful. That's the way to go. And like I said, in ALL, the adults had to learn a lot from the PED protocols and never be ashamed to learn from others because life is only one constant, that's learning. Okay, so thank you guys. And you must have a robust referral system. And for that, create awareness in the general population and the medical fraternity. Tell them the scope of BMT. Don't send your patients when they are cooked and burnt for a BMT. And tell them when is the right time to send it. Okay? And the cost of treatment, the out-of-pocket expenses, we must find ways to decrease it. One of the ways is insurance. Other ways to have governmental involvement, state and central funding. I won't go too much here, but for the youngsters who are on the platform today, many students are there. So I thought I must just cover the basics. Any non-functioning stem cell, whether it's due to a malignant process or due to a genetic process, if it's not functioning, it's bad. You want to ablate it, and that preparative process is called conditioning. And you knock off both the hematological and immunological functions. You got to rescue this by taking stem cells and a cocktail of cells with stem cells from either the bone marrow, peripheral blood, or the umbilical cord to restore both hematological and immunological functions. And the nomenclatures with time will change. Traditionally, it was called bone marrow transplant. Then we thought it was just CD34, call it hematopoietic stem cell transplant. Then we realized it's not, it's a cocktail of cells. It's not only CD34. So we call it now hematopoietic cell transplantation is the term you all should use. You can have autologous, allogenic, or syngeneic. You can have the indications are widening. So if you see our own guidelines, we've adopted the EBMT with permission, and there is very clear standard of care to clinical option to experimental. So I think everybody must go through it, and it's expanding. This is just a summary: neoplastic and non-neoplastic. And if you want to see the grouping, it can be stem cell disorders, red cell disorders, and the largest group is the white cell disorders, whether it's malignancies or immunodeficiencies, and some solid tumors. So I think like a good surgeon knows when not to operate, it's important for a transplant physician to know when not to transplant. I think that's so important. And as you go along, you become more senior, you learn that. And I think that's an important difference between just pure medical oncology and hematology. Hematology needs a little bit more mentoring. It needs a little bit more tutoring to learn the tricks of the trade over some years to know when not to transplant. Okay? So when to transplant, everybody will jump into it. And then you burn your fingers a certain number of times, which should be avoided. So you see, stick to a guideline. And ELN is a great guideline. You see the risk groups. So we know the favorable. I don't agree with this word favorable. I've actually written to these fora saying there's nothing favorable. It's either it's the best out of the lot, but it also kills. We know that all of them don't get cured. So it is either standard risk or the best of the lot. So, but nothing is favorable in leukemias. So here you see the adverse group, don't waste your time. So, 20, 30 years ago, we used to all, keep sticking to chemotherapy. They kept relapsing. By the time we transplanted them, it was a cooked patient who got complications and never survived. So today we know upfront how early to transplant him. So prognostication is so important. You must know about prognostication. Like this, you have the ELN working party, which said, if you can't give it more than 10% benefit in the DFS, you may reconsider your transplant, whether it's a risk assessment or the availability of a type of donor and the risk factors. Same thing you see, CML. My largest chunk of transplant I did in the 90s and early 2000s was CML. Then came in 2002, the TKIs, and CML went out of the window. But has it gone out of the window? Answer is no. We still transplanted in the advanced disorders and the non-responders, okay? So we should know who they are. And for that, prognostication is so important and monitoring is so important. And you see this allogenic hematopoietic stem cell transplant for AML cases in CR1, a meta-analysis. Okay, now we already know this. When not to do transplant, everybody will jump into when you have to. You don't do for a CBF. You obviously don't do for APML. So you should know these categories and revisit them and teach, educate, learn. Likewise, in adult ALL, our results were never good. While the ALL in children is a success story. We are talking of 90-95% in the West, and we are also catching up. But ALL in the adults is improving by learning from the pediatric age group of transplanters and hemato-oncologists. And we now know that immunotherapy has come and is real. And there will be a day, can we have chemotherapy-free treatment of things like ALL to minimize our toxicity? Then we got some tools which were not there before when I started transplant for allogenic HCT. And I must thank my resident Sandeep, who helped me to get these next few slides, because they were last minute thoughts. I said we must put it. So the comorbidity index you must calculate. These are on the left, all the events organ system wise. It's described what is okay and what is not okay. And then there's a scoring. And you can see the green is all 1, the yellow 2, and the red 3. On the right, you see the graphs. If your comorbid index is more than or equal to 3, you have the most non-relapse mortality. And if it is 0, you have the best non-relapse mortality, which is half of the 3 or more. You see the person survival with 0, 80%. And with the moment you come to 3 or more, it's 40, you see? And same thing with, you must use a score. Whenever you get your patient in, start doing dynamic EBMT scoring, 5 variables, and you have scored them from 0, 1, and 2. So if anybody's low risk is 0 to 3, survival is over 50%. If it's high risk, it's more than 5. Survival falls by 40%. It's 10%. And this is again for the youngsters here. I'm not going to go through it in detail, but suffice to say, these are the steps conventionally followed in BMT. And HLA has been a challenge. We as a country have been involving, standardizing it, validating it. We've got it wrong many a time. Patients have suffered, but we have learned. We have come a long, long way. So we have class 1 and 2 molecules. Class 1 is omnipotent non-nucleated cells. Class 2 is mainly the immune system, B lymphocytes, activated T lymphocytes, and the APCs. And class 1 can be HLA A, B, C, and class 2 can be DR, DQ, 10 out of 10 match as recommended in the EBMT. Now, ABO system has 4 possible combinations, A, B, O, and AB. Fantastic. HLA system has more than 1 million combinations. So we are navigating through 1 million combinations in finding a donor and a match. The chance of finding a match donor, 25% in a sibling, while if you have more siblings, more the chance. But mud donors in the registries have improved this. And the donor selection, a matched sibling donor is the best donor, while you can have a mismatched family donor, which if you search in mostly available, especially in the Asian part of the world. And you have the UCBs also, you're in the public cords now. So this is the wheel within a wheel, the serologic versus DNA typing. You say from the serology, the broad specificity, we have come to the allelic level, the low resolution, the intermediate to the high resolution. And especially in the mismatched and challenges like that, we obviously must make sure that we got it right by high resolution. You see the number of alleles, it's immense. So you see, how much we have to actually shortlist and refine and see who are important, who are not important. Okay, and the risk of graft rejection, the more the mismatch, you can see 25% if it's 2 or 3 antigen mismatch will be rejected. And it's good to have a cryopreservation facility because all your lymphomas and wherever you need to store before you transplant an autologous, and especially in registries, you have to have them. And very often the donors come from abroad, he comes, gives and goes. So a cryopreservation facility, all of us have it. Can be a dump freezer -86 or a liquid nitrogen -186. And DMSO is what you use as a cryoprotectant from 5 to 10%, depending on the institutional practice. You must have a venous access at the SVC-RA junction. This is a Thal kid who's now grown up as in college now. And so what is conditioning? Basically, we thought in the 80s, 90s, conditioning, you blast the marrow, kill all the bad cells, and you thought you're there. Everything is fine. But we now know it's not so because many relapse. They relapse because they were residual diseases. And this has to be killed by graft versus leukemia effect. And now we know that we have older patients because in hematology, most problems occur after 50 and they were never transplanted. So people, clinicians are restless creatures. So they researched and found non-myeloablative transplant and reduced intensity conditioning can include more than 50 years. And we rely a lot on the graft versus leukemia effect, and we can minimize the transplant-related mortality. And this is a standard cartoon which shows on the left bottom minimal cytopenia and the top myeloablative irreversible cytopenia, mandatory HC support. In between you have the RIC. So this is an operational definition of conditioning of NMA to MA. You can have stem cells, these are our patients, bone marrow and the GA or apheresis or from the cord. We have done all these from the 90s and we are among the earliest in the country to do all these and with reasonable results. This is how the marrow looks and this is the dose you're targeting and this is the engraftment definitions which you must know. And then comes the real trick. How do you monitor post-engraftment? So if you look on the right side graph, if you see before transplant, you see the donor DNA grafts at the recipient. Then you see after transplant, if there's a complete chimerism, it should be looking like the donor. If it's mixed, it's a mixed chimera. If it is complete recipient, you have a failed transplant. So this is important, and we do this monthly for up to a year. People, have different institutional practices, but this really helps you. And now comes into play the MRD, and this also, slide was made by one of my residents, and thank you, Sandeep. And here you can see AML, ALL, and multiple myeloma, the MRD levels. MRD is coming to a big play. So should you transplant only at MRD negative, or can you also transplant MRD out positive? What are the outcomes, and how do you use MRD as a tool to intervene? That's the lesson we are learning, and that's the lesson we got to perfect. And we still are not there. The jury is still out on this. And now it comes to the GVHD, GVL part. GVHD is nothing but an immunological reaction where the donor T cells attacks the host antigens because of HLA disparity. Okay, main targets, liver, skin, gut, all organs can be affected. GVL is a graft versus leukemia where the T cells target the residual leukemic cells which still survive after your conditioning. Okay, and now we found in the beginning, people who get GVHD too well, the leukemia doesn't relapse. So we found there was some commonality. But then we also saw that GVHD increased the morbidity and mortality because the moment you put immunosuppression, you have other problems of infection and whole lot of other problems. So can we tease out GVHD and GVL? To some extent we can, but there is more work to be done here. Okay. So the cellular strategies for separating GVHD from GVL. Now this paper is on haplo, and here you can see the cell depletions that have been done over a period of time. In India also we're doing it now. Clinimax we are the earliest to get Clinimax actually in Army Hospital in 2004-5, and alpha beta depletion to prevent GVHD, gamma delta to facilitate engraftment, immune reconstitution, reduce infections, and they also have a GVL. And the naive T cell, the CD45RA T depletion to enhance GVL and immune reconstitution. The Treg, which is so important, which controls GVHD and tries to spare the GVL. The NK cells we need for the GVL effect, and the CD19 B cell depletion to prevent chronic GVHD. So you know how rituximab has been used, a lot in the past couple of decades. This is a pictorial diagram of what I just told you to show GVL and GVHD, being teased around what are the cells. So this is a very, very important slide for the youngsters who are on platform. It is a crime. It's a sin. If any of your bag, which was irradiated with 25 grays, has not been irradiated because of a technical error, or your equipment is out of order, or the decay has occurred of your source. So what's on your right bottom, the indicators is a must. And the audit should be done a month, a log book should be maintained, and all your residents and nurses should not sign out that component unless you see that the color changes occurred. And the color change is a must. So irradiation prevents transfusion-associated GVHD, which is a killer. This is an unfortunate patient from Myanmar, where you can see on top, the marrow gets wiped out, 85% plus mortality, and bottom the skin biopsy, complete, you can see necrosis. Supportive care is a chunk where the money and the cost goes. And over the years, your antimicrobials, antivirals, antifungals, they've all improved. Your cellular components in your transfusion medicine support have really improved. So the cost has increased, but so has the outcomes. Complications are many, as I can see here, but you must concentrate on reducing the regimen toxicity and minimizing the chances for a VOD by using the right conditioning regimen and right supportive care. And when you plan a transplant, plan what is the GVHD prophylaxis I'm going to give. Don't just blindly go, this is MTX-CSA and this is PTCY. You must think about what have you used, what is the disease status, what are the patient, what are the risk factors, and what do I want? So you have to, a lot of thought goes into this. So I would say it's personalized. So this is personalized medicine, individualized medicine. Okay, and these can be in the headings. Allogenic mainly is GVHD, acute and chronic. Autologous, it's mainly relapse. Infection is common to both. And for me, I find infection, the viruses as a challenge, and the resistant fungi a challenge, and the MDR bacteria, the multi-drug resistant, both GNB and GPB. So these, we must have a microbiology labs on board. We must be aware what's the bugs in our hospital. We must be aware what to do. And accordingly, you must justify what you're using. And don't just throw all that you have into every bag that you actually encounter in a febrile neutropenia. You must justify what you use. And this is some of my patients in the earlier years. Acute GVHD, advanced, first one, CML, LO, serology typing. Later on found that, she was not a full match really. And the skin peels off like a high-grade burn. And you can see this child, thal child, serology matched, sister, female to male transplant, twins, one survived, one didn't. He purged out his gut. Hemorrhagic cystitis, we don't see it much today. We used to see it. It can be regimen-related, cyclophosphamide, or virus-related, okay? And chronic GVHD can be very, very challenging. We go very happy. He's engrafted. We have got through the 100 days. And then comes the chronic GVHD. And this lady is CML, and you can see her jaundice. Her liver was fully fibrosed. And we published this. It's the vanishing bile duct syndrome. Not common. She was a candidate for a liver transplant. Again, we found that she was not fully matched. We had a repository where we could store many samples. So some samples were analyzed even later. And I think that's another thing to put history in perspective. The skin looks like an autoimmune disorder, and this was her skin, like scleroderma. Now, donor registries, in good Caucasian registries, 70 to 80% international. While in ethnic minorities, Asians, Blacks, it can be as less as 20%. Because the pool, they have to contribute more, they have to donate more. Okay? And you must know what is the BMDW, established in Netherlands, nearly 40 million cell donors, 8 lakh cord blood units, 100 registries, 47 cord blood banks are all registered from 55 countries. And this is accessible, and one must actually know what it is and how to use it. And these are our Indian registries. Datri's done a great job. MDRI is very much there. There are others also, and we actually have visited most of these, and we need governmental help to expand this. We need expansion. We need more drive. We need more money. There are so many people who don't know what it is. And then came a savior in form of haplo. And if you see the bold here, the most recent EBMT activity report described haplo as a family donor with 2 or more loci mismatch within HLA A, B, C, DR, B1, DQ, B1. This is fine. So you will most probably have a donor within most of the families. And the PTCY, the great one, these are 2 for me, a Nobel Prize in hematology. So, when you use cyclophosphamide, it's metabolized to phosphoramide and mustard and acrolein, which kills all cells which are in G1 and S phases of cell division. Now, stem cells are blessed with aldehyde dehydrogenase, which is resistant to cyclophosphamide and its metabolites. This is used. So the alloreactive T cells on day 1 and 2 multiply, and 3 and 4, they are sitting ducks. So you shoot them down by using cyclophosphamide on day 3 and 4. This is the easiest explanation for PTCY. Okay, CIBMTR took off in 1972. And if you see, they're doing over 20,000 allogenic and autologous in a year. And if you see, the CAR T cells is going towards 4,000 in the US, which is great. And if you see by donor type, you see the mud is the highest in North America, followed by the related donors. And you see the haplo coming up, and you see the cord actually coming down. And if you see the disease type, AML and ALL are right on top. In pediatrics, obviously ALL is on top, closely followed by the AML. And if you see pediatrics by donor type, same thing. MUD and MRD are right on top. But I want you to see the crossing of the umbilical cord coming down and the haplo going up. This is a very significant cross. Okay, and if you see the PEDS by indications, ALL number 1, followed by AML, thalassemia right at the end. In our country, the story is different. So ISBT was established in 2004, though I think the birth occurred in 2003. In 2003, I was the joint organized secretary for the APBMT held in Delhi. Big conference, 3 5-stars. And as a matter of fact, I did a satellite symposium in the Taj, and these are the 10 people who attended it. This is the first time we said we must put together a transplant registry. And over the years, I did hand over whatever I have to Vellore. And that was the birth of the starting. And I did flash these minutes in one of the ISBMT's earlier years when I used to give talks there. So that was the birth. And now from 10 centers in 2022, 114 centers, nearly 27,000 transplants. In the armed forces, which is the largest networked hematology setup and transplant centers in the government setup, is the armed forces. And you see 27,000 transplants, allo auto graphs are shown. The dip is in COVID. You see the indications for SCT as a whole. Myeloma tops it, nearly 1/4, followed by AML, 15%, and thalassemia, 12%, followed by the rest. If you compare the PEDS and the adults after 12, the data has been analyzed. In pediatric indication, thalassemia is the largest, followed by hematological malignancies. And in adults, it's autologous myeloma is the largest, followed by AML. This is all transplants, allo and auto put together. If you take only allo in pediatrics, thalassemia is still the largest, followed by ALL and also by AML. If you see the adults, AML is the chunk, followed by ALL, and of course, bone marrow failure syndromes is a large chunk again here. It's nearly 16%. And if you see the autologous in pediatrics, neuroblastoma is the largest, followed by Hodgkin's lymphoma, other solid tumors. In adults, it's definitely myeloma, followed by the others. And if you see the type of donor, it's MRD, followed by haplo in pediatrics, and it's the same in adults. This is unlike what I showed you in the CIBMTR. And ICMR draft guidelines, I have already shown you. Now I'm coming to the cellular therapy part. This is the last part of my talk. The stem cell research has to be regulated. And the ICMR and DBT with the CDSC or DCGI have been excellent regulators. I've been a member of these groups for the last 15, 20 years. We have stem cell expert groups. We have legislated actions. We have regulatory rules, and they act as the national watchdog so that you follow the ethics and restrict the use of stem cells only for clinical trials outside BMT. That's the only standard of care for stem cell use today is BMT, besides approved cellular therapy, which comes under the umbrella of BMT, which I'll show you. And of course, CAR T cells in public and private is also a reality. Okay, so these are the various things from 2002. We have worked on these documents. Up to 17, these are all available on the net, which shows you how to do stem cell research. You just can't take stem cells and put it in saying, I'm going to treat autism, I'm going to treat Duchenne muscular dystrophy. It has to be in the realm of a clinical trial, approved by your ethics committee and either by CDSCO or by DHR ICMR. That's very important for the younger people to learn that ethics and regulations cannot be violated. You'll get into deep trouble. And we did 3 such trials published in good journals This was for strokes, for regeneration of neurons. We published this in stroke, and we did this in the early 2000s. Then we did for cardiomyocyte regeneration. I was the PI for this, and we actually put these stem cells into the coronary arteries for cardiomyocyte regeneration. One of the largest trials done in the world, 250 each, 125 each limb, total of 250 patients. This is for critical limb ischemia, for diabetes and TAO in smokers, where we found there was regeneration, angiogenesis, and prevention of amputations was the endpoint. Okay, these are some of our publications which come out of our work. Some of my young patients in the early 2000s in RR Hospital, Delhi. We put together our army hospital experience, in our own journal, which is indexed in the PubMed. And we have now obviously over about near touching 1,000. These are our experience of 700 odd patients. And we reviewed our country's situation with all the top centers put together. Cellular therapy, this is what the youngsters must know and actually come on board. We all have been using DLI. See the red. DLI involves the infusion of lymphocytes, particularly T cells, extracted from the donor to the body of the recipient. And these cells are supposed to help you in your GVL, immune response, and reduce the risk of relapse. And these are the cell doses that you can use. But this is as per the institution policy. But it's good to start at a low dose. And you don't forget, you can get GVHD. So you must watch out and be careful that where you are and use it judiciously. CAR T cell therapy, it's a living drug you have created. So immune escape occurs. So these T cells become important. They're supposed to have picked up those cancer cells and finished it off. But he had no bullets. So you get the bullets back for these T cells and make it a living drug to attack the residual cancer cells. And actually, the generations depend on the co-stimulatory molecules. The more of the co-stimulatory molecules, less will be the on-target side effects like cytokine release syndrome and others, and even the off-target effects. Emily Whitehead, famous, first one in a trial in 2012, got the first CAR T cells, still alive, and she is cancer-free. And India has got its own first CAR T cells, more to follow. I know Dr. Sunil and all have already trialed the other ones. Imunil is in the pipeline, and I'm sure it's a question of time. I was the co-chair of the DBT's funding for CAR T cell. We gave it to 8 governmental and private agencies, and those governmental agencies and CMC Vellore, HGPGL, Lucknow, and a few others are on the anvil of coming out with their own therapies. So why is, in the last few slides, why are transplants getting safer? You know what to select. You know how to prognosticate. You standardize your supportive care, and you also have your SOPs for treating GVHD and other complications. And education, training. And with this comes the improved competence and the center experience. That's where they always talk when you have a meta-analysis and others. What is the center experience? That makes all the difference, you see? So you have to go slow. You have to learn how to crawl and walk before you run. Otherwise, you'll fall. So this you must go through, and we want everybody to run, but go through the process. Recent advances, I've already told you all this. What I've not told you is donor-specific antibodies, class 1, 2, and we desensitized protocols are there, and we are all doing it nowadays. Okay, and the timing of transplant, MRD usage, and we talk about immune reconstitution, which is a big concern. Well, microbial infections have to be prevented. Okay, HLH, I'm not going into, but it's very much to be picked up and early and treated whenever it occurs. Problems and challenges, complex, labor-intensive, costly, donor raising is expansion, still lack of trained manpower. Poaching is occurring in the cooperative sector, which is natural and normal, but you should know how to retain your manpower. And inadequate number of quality blood banks. Microbiology needs to be stepped up for virology and mycology. We need national health program for BMT with center and state support. So you need political and government involvement. So to conclude, ladies and gentlemen, HCT is the only indication for stem cell therapy as standard of care with the cellular therapy which goes with it. All other ones fall under experimental or investigational trials with the regulatory mechanisms by CDS, CO, ICMR, DBT, and now NMC in place. Unethical use to be curbed, stem cell research to be promoted with regulations, collaborative research to be promoted, costs must be reduced, and obviously training and education are a must. So I will sign off by saying, these are my favorite lines. You must learn from yesterday, that's history. Learn from today, that you're a Karam Yogi, and hope for tomorrow. Don't stop dreaming. But the important thing, ladies and gentlemen, and my dear students and colleagues, peers, seniors, is that never stop questioning, said the genius called Albert Einstein. We have still mountains to climb, which I'm sure we will do. Thank you very much. Jai Hind.
Thank you, Lieutenant General Dr. Velu Nair. It was indeed a pleasure to listen to this very lucid history of stem cell transplant. And to end, you said, don't stop questioning. But unfortunately, we don't have time for questions now. Otherwise, there may be many amongst the minds of younger people, but they can always interact with you on some other platform later personally too. So thank you very much. Wonderful, wonderful. Enjoyed every bit. And I'm sure people have understood not just looking at history of happening of transplant, but history of all the advances that take place in every bit of science in transplant is equally important to keep pace with. I'm sure every minute there's something happening new, and we all really find it difficult to catch up with it. So we have but illustrious younger people who catch up and update themselves from on a day-to-day basis with so many publications coming out. And one of such persons that I have known closely is Dr. Satya Yadav. So we'll move on to the next session with that. And I will invite Dr. Satya Yadav to moderate the session on indications in pediatric bone marrow stem cell transplant. Satya is a director of pediatric hematology, oncology, and bone marrow transplant services at Medanta Hospital, Gurgaon. He was earlier with Dr. Anupam Sachdeva in Gangaram Hospital, and he set up the program there too. So he has many hats to his credit. I'm not going to go into great details of the CV, which is again very long. Many publications, awarded with many awards and honors, been on various committees. With this, Dr. Satya Yadav, I leave the podium to you.
Thank you, ma'am, for the kind introduction. And thank you, General Nair, for a very, very lucid talk, which like it was, each slide was so interesting. I took a lot of pictures and shared on Twitter also. So it was wonderful session, and thank you, sir. So now we move to the next session, and that's a panel discussion. And we are going to discuss about indications of pediatric bone marrow transplant. So I would like to share my slides. So can I share my slides? Let me see. Yeah. Yes. So I have my panelists. So I will invite first panelist, Dr. Deen Dayalan. He's a pediatric hemato-oncologist at MGM Hospital in Chennai. He's heading the department there and a very good friend. So welcome, Dr. Deen Dayalan. And
yeah, thank you.
Dr. Vikas Dua, he's has been my fellow at Gangaram Hospital. Now he's heading the Department of Pediatric Hematology, Oncology, and Bone Marrow Transplant at Fortis Hospital, Gurgaon. So welcome, Vikas. If you're online, say hi to everyone.
Hi, sir. Hi, everyone.
Hi, Vikas. So then the third panelist is Dr. Rajat Bhattacharya. So Rajat has been a friend for a long time, and he was a faculty in Singapore for a very long time. And now he has recently moved to India and working in Kolkata, Apollo Hospital as a head of the Pediatric Hematology, Oncology, and Bone Marrow Transplant and Cell Therapy Center. And he has a lot of experience in CAR T cell therapy in Singapore. So welcome to today's session. Rajat, if you're online, say hi to everyone.
Thank you for inviting for the first session. It's an honor.
So our talk is like our discussion is about indications for bone marrow transplant, and mainly a lot of trainees are there logged in and younger faculty. So we'll try to give them the tips of our experience and whatever is there in the literature, so that they get the right perspective about things. And if there are any further comments, we can later on take some question answers if time remains. So the first, just move the slide. Yeah. So I'll start with Vikas. When will you offer a bone marrow transplant to a child with acute lymphoblastic leukemia who is in the first clinical remission? In CR1, usually most children are cured with chemotherapy. So when would you worry, or which patients would you choose for offering a transplant in first remission in acute lymphoblastic leukemia? Thank you.
Thank you, sir, for the invitation. And I know quite a number of people are listening to us, and majority of the people who are here are junior colleagues. So we as transplant physicians, we know very well that we don't transplant majority of the patients who are in CR1. But there is a specific group, or you can say some of the patients who may require transplant in CR1 as well. And these are the patients who come to the high risk arm. The high risk ones, the pH positive MLLs, or those who are, I would say, bad cytogenetics, a bad PCR marker, and are not doing well. It is not that they qualify for transplant upfront, but in case these pH positive MLLs, bad cytogenetics ones are not doing well and remain MRD positive despite a good induction or a consolidation, whatever protocol you are using, then these patients may go on a transplant track, in a nutshell, if I have to tell you.
So thank you. And ETP is another bit of controversial thing. In adults, I think it's a standard indication for transplant. In pediatrics, for early precursor T cell, some transplant, some don't transplant, but most people go by MRD and response to therapy. So that's another possible indication of transplant.
Absolutely. So we also go by the MRD in patients of ETP-ALL. If they're doing well, if they're MRD negative after the end of induction, we treat them as high risk ALLs. But if in case they're not doing well, they remain MRD positive despite being on 4-drug induction, then we may consider these patients to go on a transplant track.
Thank you. So Dr. Deemdayalan, coming to relapsed acute lymphoblastic leukemia. So once you achieve a second remission, which patients would you choose for transplant? Would you offer transplant to all relapsed ALL patients who are in CR2, or you will still select few of them?
Yeah, thank you for inviting me. And junior doctors, people should know that 65% of the 65 pediatric disease can be cured by the stem cell transplantation. So coming to the CR2, it's depends on the duration of the first complete remission and immunophenotype and site of relapse. So it be divided into the standard risk and intermediate risk and high risk. The standard risk usually can manage with chemotherapy. Intermediate risk, if you have a patient have an MRD is negative end of the induction, that was can manage by the chemotherapy. Only the intermediate risk with comes an MRD is positive, and also the high risk patient needs a transplant. So it's and all the T cell ALL patient needs a transplant, and also based upon whether it's a early relapse or late relapse, or also based upon you should take a call.
Thank you. So any T cell who relapses, usually they need transplant, and very early relapse usually need transplant, and rest are based on MRD and other things. So fantastic. Now about those who have relapsed again after like the second remission, also they have relapsed second time. So is there hope for such patients? So Rajat, your views on such patients or refractory leukemia patients, should they be offered a transplant, or those who have had a second relapse?
So Satya, you mean they have already had a transplant and then they relapse? Is that what you mean?
Yeah, usually like they have relapsed one time and then they have relapsed second time, or they are refractory. So such patients with ALL.
Yeah, of course, yes. So just understanding at the moment, I think the only indication for upfront transplant is the 17-19 translocation. Apart from everything is MRD. And then you have these relapsed refractory and they had transplant. So, of course, with the advent of the CAR T cell therapy, things are becoming completely different. So, those who relapsed post transplant, I think Liana trial was a perfect example for us to show that, yeah, at least 50% can be cured. And that was the first CAR we have used. And the second generation. And now with the newer CARs coming, so I think we do have hope for these patients. And I must tell you, there are some who are very refractory, and science has advanced so much. I'm aware of patients who are refractory to treatment, so they're having a transplant, and then they're having a donor CAR T cell. So things are just evolving very, very fast. So I think all I tell the juniors that be aware of things which are happening, and nowadays we should, not lose a B cell ALL. We can go.
There is a lot of hope for such patients. Yes. There are still CAR T cell therapy options are there. Yep. So now the entire thing is when to offer the CAR T cell therapy. Should be offered at the first relapse, or at the second relapse, or after you have relapsed after bone marrow transplant. These things are still evolving, and we don't know the right timing, but I think the future would be earlier, and earlier CAR T cells might be offered. Now, the last question to Vikas, there is a lot of things that a lot of patients are having CAR T cell therapy after relapse or refractory patients. So would you, or what's your take on offering a bone marrow transplant after CAR T cell therapy? Is it required, not required, or what should we tell our juniors or people who are listening? That after you have CAR T cell therapy, is there any further treatment required or not required?
I think that's a fantastic question, but the answer to this is we still don't know. We still don't know who would require a transplant. I think the time will give us an answer.
Yeah, so it's evolving, and loss of B cell aplasia is something, if the B cells are coming back up, then people tend to offer transplant. But otherwise, if you are deep MRD negative after CAR T cell therapy, you may not offer. Yeah, Rajat, you want to add something?
Yeah, I think now we are learning more. So pre-CAR T therapy, there are some indicators like KMT2A and hypodeployed. They don't do that well, so they need a concentration. And high disease burden, probably need a transplant. And post-transplant, NGS MRD, I think, is coming if you have facility, NGS MRD or any MRD, and B cell aplasia. So these are the sort of evolving things. And
Thank you.
Did the Inspired Symposium, and there are some other articles there.
Great. So this was a big topic, very important. Now we move to lymphomas. When will you offer transplants for lymphoma? So lymphoblastic lymphoma, the indications are similar to acute lymphoblastic leukemia. It's treated similarly, and at relapse also similar indications. Now coming to B cell lymphomas, like Vikas, if a child with B cell lymphoma like Burkitt's or DLBCL, if they relapse, so what would be your choice of auto, allo, and how, or the role of CAR T cell therapy in this situation?
So in our personal experience, if you ask us, we all know the fact that Burkitt lymphomas are bad in case they relapse. If I have an option of a donor, a full match donor in the family, I would go ahead with the allo transplant specifically in Burkitt's. But if that is not the case, I would be reluctant to offer a haplo. I would do an auto rather than going for a haplo. That's my take on a Burkitt's case.
So learning from the adult world, in DLBCL, they usually offer autologous first, and then
in DLBCL,
but Burkitt's is more aggressive. Yeah. I agree with you, and the outcomes of relapse Burkitt's are very bad. So anaplastic large cell lymphoma, Deen Dayalan, would you offer a transplant when they relapse, and what kind of transplant would you offer? Allo, auto?
Yeah. It depends upon the type of relapse and whether it's a CD3 positive relapse. That's based upon that we can divide into very high risk and intermediate risk and low risk. Usually for very high risk, we offer the allo transplant. For the intermediate risk, we offer the autologous transplant. For the low risk, we can manage with the chemotherapy.
Thank you. So Rajat, coming to Hodgkin's lymphoma, a lot has happened. A lot of options are there. So once the Hodgkin's relapses, so what would you offer them? Would you offer them transplant, immunotherapy, or allo, or what? How you go about it at the first relapse?
I think with the brentuximab, I think options are much more. And then Autologous probably still will be some standard of care. Allograft, well, if you failed an auto, then allograft remains an option. And I know people have tried to look for CAR-T for CD30 CAR for Hodgkin's also. So again, indications are evolving very quickly, so watch out for it.
So in a chemosensitive, if you're responding to chemotherapy, then autologous transplant is a great option. But if you're refractory to chemo, then maybe allo or the newer checkpoint inhibitors and other things can be tried. So now we move to AML, acute myeloid leukemia. So because if you have AML in CR1, would you offer transplant? And if yes, which particular subset of AML patients in CR1 you would offer transplant?
Yes, sir. So in our practice, all high risk means monosomy 5, monosomy 7, any high risk AML goes on a transplant track. And in our practice, any intermediate risk patient also goes on a transplant track, because what we have analyzed in last couple of years, that if we are doing a transplant for our intermediate risk patients, the outcomes are better rather than those who have been treated just with chemotherapy. So we have moved on to doing a transplant for all our intermediate and high risk patients.
And role of auto, is there any role of autologous transplant in AML for youngsters?
In APML, we have done 2, and both of our patients are doing well.
So except APML, mostly no auto should be offered in AML, and the subset is maybe just APML. So
that's right.
Once they relapse, like if they are in CR2 or they are refractory AML, so Deen Dayalan, would you offer them a transplant in refractory AML especially, or you will just send them for palliative care?
Actually, refractory AML is very difficult to treat. The parents are willing, and after explaining the cost, I may go for a transplant, but the prognosis is very poor, especially for the refractory AML. In CR2, I usually offer them the transplant. It's an indication for doing a transplant in CR2 is there. So definitely I'll offer the transplant CR2.
Thank you. Rajat, MDS, pediatric MDS, would you offer transplant to all, or you would again do approach like in adults where they have risk stratification and they go about transplant?
No, I think pediatric MDS, they need to be transplanted. And I must say, I have now faced a new mutation called UBTF mutation, at least twice now, which is not covered in the pediatric AML MDS panel. And those are a different type of presentation to erythrohyperplasia. So MDS should be transplanted. And the good thing is that you may not need to bring them into complete remission if they have a blast percentage of 10-20%. So that is still, whether you need to give intensive chemotherapy, probably not. I would rather give the hypomethylating agents and then take to a transplant as soon as possible.
Coming to CML, so Vikas, when would you offer a bone marrow transplant to a child with chronic myeloid leukemia?
So undoubtedly, if a patient goes to blast crisis phase, then we would like to get the patient into a remission. And whether it is an ALL blast crisis or an AML blast crisis, accordingly the chemo would be given and a transplant would be offered. Accelerated, yes, we have to get these patients on a transplant track at the soonest. In case a patient is not responding well to a particular TKI, then we can think of shifting to a second generation TKI in those patients rather than offering a transplant for them.
Thank you. Deen Dayalan, so juvenile myelomonocytic leukemia, would you offer transplant to all such cases, or there is a subset where it may not be offered? GMML.
Yeah, actually, I'll give the option, but definitely we can do the transplant for JML patient.
So I think if we have to add, I think CBLs we can observe. We have seen CBLs going into remission,
spontaneous recovery, so they may be monitored, but mostly they require a transplant, what Deen Dayalan said. So thank you. Now we move to the next part about thalassemia and sickle cell disease. So as we all know, thalassemia is the commonest indication for allogeneic transplant in India. So I'll start with Deen Dayalan. So in thalassemia patients, when they come to you for an option of bone marrow transplant, do you offer transplant to everyone, or you give it as a choice? And how do you explain to them, like, is there any age cutoff when you should do transplant or not do transplant based on the age or other risk factors in thalassemia?
The classical age for doing a transplant in a thalassemia is between 3 to 7 years. With a serum ferritin less than 1,500, the matched sibling is ideal candidate for doing the transplant. But unfortunately, most of the patients comes after only 10 years for the transplant. And based upon the class 2 and class 2, I definitely offer the transplant. In class 3, depends on donor-specific antibodies, availability of the donors, and I have to explain the cost to the patient. I'll do the transplant. Definitely, at present, the pre-transplant immunosuppression is available, and then T-cell depletion techniques are available. I definitely offer the transplant, but I have to explain the risk in the class 3 and more than age group of 10 years.
So we have to
Less
discuss
than
the
10
risk
years.
with the family based on the age and their iron status and other factors and the size of liver, spleen, etc. So the good discussion with family is a must. As the age is more, in younger patients, you are more confident success is far more and less complications. So it has to be discussed with the family and then go about offering a transplant in class 3. But the class 1 is, there is no hesitation, we can offer easily, and class 2 also results are good. Now coming to sickle cell disease, so Vikas, when would you offer a transplant to a child with sickle cell disease? Do all sickle cell patients need transplant, or you will select them based on something?
So undoubtedly, this is one of the hemoglobinopathy in which those patients who are doing well, those who don't have frequent pain crisis, no chest syndromes, no strokes, no major issues, we don't transplant. But what is been written on the slide, if you see, those who don't respond well, even after going up on the dose of hydroxyurea, patient is coming to you again and again with pain crisis, yes, we would offer a transplant. Somebody who has had a stroke is at a risk of a stroke later in the life again. So we offer a transplant to these patients. And it's always important to discuss with the families that in sickle also sooner the better is the dictum. Because if you have an end organ damage, so the transplant may not be able to rectify the damage which has already happened. So it is always important to offer a transplant early, but looking at whether the patient qualifies for a transplant or not by looking at the indications is also another important thing.
And again, matched sibling is possibly the best option. And now data of haplo is also quite promising in sickle. Thank you. So now we move to aplastic anemia, and Rajat, acquired aplastic anemia, severe aplastic anemia in children. So the traditionally we know matched sibling, and if not available, then MUD also has equally good results. And if both not available, then immunosuppressive therapy was the other option. So now coming to haploidentical transplants. So what's your take and what's the literature says? Where is haplo standing in severe aplastic anemia? Should it be offered, not offered, or how we go about it?
Yes. So my take is there are two ways you can do haplo in severe aplastic anemia: PTCY and T-cell depletion. So if you can salvage a graft rejection, then take the T-cell depletion approach. And if you can confident on managing a GVHD, then take the PTCY approach. But if you're not having facility, I would worry a little bit about the severe aplastic anemia doing a haplotransplant at the moment.
Yeah. So it is still evolving. It's not established thing in the guidelines, but the guidelines will change soon. There is very promising data. So maybe Vikas and Deen Dayalan can give their inputs on haplo if they have experience of aplastic anemia, if they would like to comment.
We did a lot of around 5 to 10 patients on haplo with aplastic anemia. Actually, they're doing well. Actually, you should give the option to the parents, and the cost should be discussed because there's no other option for them. So I think
we need to publish this data from India, and Gaurav has already published one multi-centric data, and we have published a small series, but more data needs to come so that guidelines can change, and we have to change it, and haplo has to fit in somewhere in severe aplastic anemia as an option. It's a good modality. So now coming to inherited bone marrow failure, and so I'll ask Deen Dayalan about these disorders in general, that whenever a child comes with aplastic anemia label, so should we rule out inherited bone marrow failure, and what test we should do so that we are sure that it's not acquired and it's inherited?
Yeah, before taking for the transplant, I'll always do all the patient for the clinical exome sequencing or whole genome sequencing to rule out inherited bone marrow failure syndrome. because this patient is very sensitive to the chemotherapy. So definitely all aplastic anemia will do this protocol, then only take care for the transplant. And Fanconi anemia is depends upon the if the match sibling donor available, I'll go for it because the chance of secondary malignancy is high, and also the more chance of AML and myelodysplastic changes.
Other thing is the donor also has to be screened if the patient has Fanconi.
Sorry, that's very important. The donors to be screened. And then even we can applause can given for we can try for Fanconi anemia. That was coming in the good major way.
Thank you. So now, Vikas, if you are online or not there. So indications, so indications for bone marrow transplant in primary immunodeficiency. So starting with SCID, severe combined immunodeficiency. So would you offer transplant to all babies with severe combined immunodeficiency, or there is any exception or any problems in particular subsets where you would say that transplant is more complicated?
I think a transplant is to be offered.
It's a medical emergency.
It's a medical emergency. We can debate whether to use conditioning or not. That's a separate thing. But each and every patient who comes to you, who comes to a pediatric hematologist who's been diagnosed with SCID, whatever the SCID type is, should be offered the transplant at the soonest.
So certain subsets like Artemis or some other subsets like which are radiation sensitive, so there the conditioning would be the main choice how you go about it. But
absolutely, transplant is required. We can debate on the conditioning, whether to use, not to use, what conditioning to use, but transplant is to be offered.
Then other conditions like combined immunodeficiency, Viscott-Eldridge, HLH, they are so in HLH when the child doesn't have familial HLH or there is no mutation detected. Then when would you offer a transplant? Would such patients need transplant or not need transplant? Over to maybe Deen Dayalan, can you answer that? HLH patients acquired versus when we initially don't find any mutation, such patients, should they offer transplant? When would you offer?
Yeah, this depends upon whether the child is having a recurrent disease.
Yeah, so repeat attacks, then it has to be offered transplant. And CNS involvement, if it is there, then transplant.
Clinically suggest, transplant.
Okay. So metabolic disorders, and I think Rajat, if you can comment. So most of them are very rare, and there are certain ones which are more popular or well known, and where most people understand the indications. But then others are sometimes you don't haven't even heard the name of that disease, and patient comes with a report, and transplant somewhere on Google or net is mentioned that transplant 1 patient done, 2 patients done. So how do you go about offering a transplant in such rare metabolic disorders?
Yeah, the same thing. Google and ask Rob Wynn to see whether you will transplant.
I've discussed with some expert who have some experience in metabolic disorders like Rob Wynn, Jab Bolens, or even other few, Vinod Prasad and other people who have done a lot of transplant. It's always good to discuss with them and see their experience. Or take a ethical clearance from your ethical committee as a case-based approach. If you are strongly convinced that transplant might help, there is some biochemical pathways, some established, published data that the transplant might help. But single first patient, second patient, third patient is always difficult to go about and decide what to do. You don't know what would be the course. So that's the challenge. But metabolic disorders, X-linked adrenoleukodystrophy, standard of care, MPS type 1, type 2, and type 6 are some. Type 1 and type 2 are standard of care, and type 6 is clinical option. And then there are a lot of rare disorders, metachromatic leukodystrophy, etc. So that's fine. Now coming to autologous stem cell transplant, we all know that neuroblastoma is something commonly. These are high-risk neuroblastomas. We offer them transplant. Brain tumors, sometimes medulloblastoma, sequential St. Jude's type of approach can be given, and at the relapse setting we can do. So last but not the least, Vikas, would you comment on autologous stem cell transplant in autoimmune disorders? Like maybe a comment on multiple sclerosis, particularly, that can transplant be offered? Is it helpful or not?
Undoubtedly. So though we as pediatric hematologists have not done a transplant for multiple sclerosis, but in our hospital, our colleagues have done more than 100 transplants for MS. And there are specific indications of doing a transplant in MS. I don't know, actually, because we don't do the transplants. But yes, MS is one of the indications in which autologous transplant can be offered.
So this is a new field which has opened up, resetting your immune system, especially autoimmune disorders by autologous stem cell transplant. And even CAR T cell therapy is being tried for refractory SLE because your B cells are making all these antibodies, and CAR T cell can wipe out your B cells. So these are new things. The things are evolving. And I think we'll finish here. And any comments from anyone else? Otherwise, I will hand it over to Satyendra Katewa to conclude today's meeting. Thank you.
Good evening, everyone, and thank you, Mamta ma'am, Lieutenant General Dr. Velu Nair, SP Yadav.
I'm sorry to interrupt you, Dr. Satyendra.
Yeah,
I think there is one question. If
okay.
I think it was probably not discussed, so shall I mention?
Yeah, very important, please. So let me read the question, and then anybody can answer it. Would you consider a fully matched sibling with a heterozygous Fanconi gene? Would you consider as a donor? Second scenario, fully matched with compound heterozygous defect as a donor. So out of the two, which one will you select?
So absolutely, if we have a heterozygous donor, as we are doing half-match transplants for Fanconi's, heterozygous person can become a donor, but we would be hesitant if it's a compound heterozygous state.
Okay, can I add something? Just 5 seconds. So there is some data that has been published by Midwest, and that is that even if you are selecting a heterozygous Fanconi donor, it's better to go ahead and do some the breakage. They almost kind of gonna come out. I'm sure we are all doing it, because sometimes the other one is not known and we are not doing the whole genome sequencing. So maybe there is a novel one. So it might be a compound one. So now probably it is for the audience that it's going, the guideline is going to come in that even if you are having one heterozygous, please go ahead and do the at least a chromosomal breakage, and then you select it.
Thank you.
Okay, guys. So it's the most important time of the event. Thank you very much to the Mamta ma'am. You are an inspiration. And Lieutenant General Dr. Velu Nair, there is nothing much we can say about you, sir. You are a beacon of hope for everybody around. Dr. SP, sir, you are a teacher. Dr. Rajat, such a humble, experienced, learned man. Dr. Vikas, Dr. Deena, they are my friend. And thank you all for your precious time and attention. It's a humble start by all of us. It's not we 3, 4, 5. No, it is all who have created this. And this is created to learn by the published science, the discussions, the experts. It's all for us. And it's a promise that we will try to line up different topics which are covering the basics and the finer aspect of transplant over the next 1 year. It's a baby step, but someone has to take it. We have taken it up. We are trying to make sure that every last Tuesday of every month. So this is a monthly. Last Tuesday of every month, we will be meeting with the educational webinar, same time, 7:30 to 9. And it's a great evening, guys. Thank you very much once again. We are all humbled. You are a part of a baby start, but a very, very historical. Thank you very much and have a great evening. Thank you, everyone. Thank you.
Thank you. Thank you.
Thank
Good
you
night,
so much.
everyone.
Thank you.
Bye-bye.
Bye-bye.
So, just a second, last but not the least, thank you, MQO team, for providing us this platform. And you have always supported these academic events, and we hope that you will continue this support in the future as well. Thank you very much.
Thank you, sir.
Thanks, guys. Thank you.
Thank you.
Bye.
Thank you.
Bye.
Thank you.
Bye.
Bye-bye.
Bye.